Okay, so we are live on YouTube and Shilpa madam, I think we can start the session. There is no problem.
Yeah. Hi, everybody. Welcome to yet another session on Fertility Masterclass by Dr. J. So we will be starting with the stimulation protocols in the next 4 sessions. So today's will be the agonist protocol, which is, I think, one of the most standard protocol for IVF stimulation. And I think everyone needs to know about this because this is a go-to protocol whenever we are in trouble. And I will not waste much time. I will hand it over to Dr. Jay to take it forward.
Right. So thank you, Shilpa madam, and to all the people who are requesting for more lectures, kindly contact her directly as far as lectures and their requests are concerned, because all this is her initiative. So what we are going to discuss today is GnRH Agonist protocol. I'll be switching to the whiteboard in a little while. It's important for people to understand that more than 95 to 98% of the stimulation cycles as far as IVF is concerned, which currently happen anywhere in the world, is antagonist, because antagonist gives you a much more better convenience. Okay, there are very few people who are going to be opting for agonist protocol as a standard protocol, right? Very few people. But remember, there are certain special situations. So there are these special situations which I would just like to describe first. It is a very good protocol when you are a normoresponder. Okay, that is the first thing which you should understand. Agonist protocol is also a very good protocol if you have had previous 1 or 2 attempts of antagonist protocol which have failed. Okay, and if you have time available with you, then agonist protocol is a good protocol provided you want to do a fresh transfer. Okay, it is a good protocol when you want to do a fresh transfer provided you have that much time available with you. All right, so these are 3 indications. The 4th indication which I use predominantly, and I think it is better in just my personal experience, because I know that there are enough RCTs and everything which has proven that even in endometriosis, the protocol, antagonist protocol and agonist protocol give equally good outcomes. Okay, but in my practice, what I have seen is post surgery, if the patient is taken up and if she is a normoresponder, that means antral follicle count approximately, let's say 8 to 13, and if she is on the slightly higher side of age, let's say between 35 to 40, in these type of situations, the agonist protocol will work slightly better as compared to the antagonist protocol. Okay, so I will switch to the whiteboard to give you a brief description as to how you are supposed to practically do this protocol in your private practice. Okay, so Shilpa madam and Kiran sir, requesting both of you to be unmuted, and I have shared the board here. So I think Shilpa madam, the board is visible, right?
Yeah.
All right. So whenever we are trying to talk of agonist protocol, it is important to understand what we are trying to stimulate as far as any natural cycle is concerned. All right. So if we look at a natural cycle, let's say we are looking at day 1 or 2 or 3, okay, of a natural cycle. So let's say we are looking at day 1, 2, 3 out here. Okay, approximately day 20, 21 in the previous cycle, if the implantation has not occurred, okay, if there is no implantation in that previous cycle, what will happen is there will be degeneration of the corpus luteum. All right, and this degeneration of corpus luteum, okay, will cause reduction in progesterone values would go down, but simultaneously even estrogen values will go down, and it will cause a slight increase in FSH. So the late luteal FSH which rises, this late rise in the luteal FSH, okay, this is the luteal slight rise in FSH, which will cause recruitment, okay, of some follicles. All right, and this recruitment of some follicles will then be visualized to you as some antral follicles, which are then recruited in the late luteal phase. All right, so this late rise of FSH is slightly important in order for that particular cohort to get recruited, and that is a very important point which you have to understand. Okay, this is predominantly because we assume that ovulation would have occurred on day 14. Okay, that is your assumption of ovulation, and as a result of which the implantation normally occurs 7 to 8 days later. All right, If there is no pregnancy, the corpus luteum will degenerate because the LH which is generated from the corpus luteum will not be sustained enough. There will be no HCG to replace it to sustain the corpus luteum, and which causes the degeneration, which in turn causes this particular phenomenon to happen. Okay, this is physiology which we have all studied in our textbooks. Probably we might have forgotten as well. Okay, so day 21 or 22 of the previous cycle, for approximately, let's say, 7 to 8 days till you reach day 1 or 2 or 3, okay, of this cycle. All right, from here onwards, daily, the patient is going to be given every day. So what I give is I give 0.1 ml triptorelin, okay, which is commonly available as decapeptyl across the world. All right, it is available as decapeptyl across the world. It is manufactured by something called as Ferring Pharma. Okay, it's a standard product. This much, this giving of triptorelin here, when you are administering triptorelin on day 21, 22, what it does is, after causing an initial flare, okay, after causing that slight increase in FSH and LH, okay, that slight increase in FSH and LH, which is enough to recruit this, which is very, very important. So see, it mimics this. It causes this recruitment, but after that, the down regulation which is ensured from here, it ensures that when the patient comes back to you on day 2 or day 3, all the cohort, is streamlined. So it is a cohort where there is no abnormal response. It is a very standardized cohort of follicles. Okay, all of them are almost of the same size. Now, this is important for you. This particular cohort is very, very important for you. Okay, especially in the cases which I mentioned, that is in cases of endometriosis. Okay, in cases of normal responders, okay, between the age group of 35 to 40. Okay, in cases of ANTAG failure cycles, that means ANTAG protocol has been used prior and there is a asynchronous cohort or whatever, and the cycle has failed. Because one thing we know for sure, okay, we know this for sure, for every extra metaphase 2 oocyte you obtain, okay, in this particular age group, all right, you are definitely adding approximately 5% to your live births. Okay, and if this is your target, then agonist protocol is a very good protocol for these type of special situations. Okay, obviously, the fourth thing which I have mentioned is when you want to do a fresh cycle, when you want to do it. Okay, so when the patient comes to you on day 2 or 3, you have a beautiful synchronized standardized cohort, but there is a severe amount of down regulation what has occurred. So just to give a small information, what is this antagonist actually? This is what is the antagonist. It is a GnRH antagonist, gonadotropin receptor antagonist. So what it does is it goes and binds to the GnRH receptors, and then it causes down regulation. All right. The mechanism of down regulation is such that after a particular while, this down regulation, a fresh batch of receptor will be induced. Okay, but even before that fresh batch comes in, you have given the second shot. So there is going to be a sustained down regulation. Now, because there is a sustained down regulation, you must remember that this is a cycle where you have reduced values of FSH to start off with. You have very reduced values of LH to start off with. Okay. As a result of this, when you are starting to stimulate the cohort here, okay, on day 2 or day 3, when you start to stimulate the cohort, let's say you are giving for the first 7 days, you are still daily giving your agonist. Okay, some people want to give a half dose of agonist to reduce that stimulation, but it's always better to give. This is my practical experience. Though papers have shown that recombinant FSH for the first 5 days is enough, there are some people who also request for addition of recombinant LH, but compared to that, just HMG alone for stimulation in an agonist cycle is something which is very good. It works extremely well. And when the patient comes to you on day 7, what you typically notice is that the entire cohort is beautiful, linear. Everybody is of the same size. Okay, you have this wonderful 12 millimeter to 13 millimeter size of this cohort after 5 to 6 shots. Normally, I would recommend to start off with an HMG of 375 international units. Because of this severe suppression, you must remember agonist cycle will require slightly high dose. Okay, it will just require a slightly high dose, and 375 international units is a good thing if you want to standardize and start off your treatment. Now, because you are daily giving agonist, let's assume the patient has come to you now on day 10. You, of course, don't have to give antagonist because there is no LH at all. Okay, you don't have to give anything like that. When the patient comes to you on day 10, you will typically see these follicles beautiful, right? All these follicles have become 17, 18 millimeters. All of them look to be very nicely synchronized. And these people are going to be people who are going to be stimulated the best, okay, by giving HCG. Okay. Of course, when you are using agonist, there is no GnRH agonist trigger. HCG is the best trigger to work over these follicles. So commonly people would ask, Arey, you are saying HCG is the best trigger to work on these follicles, but Jay, you are wrong. You just mentioned that there is severe suppression of FSH and LH, and HCG is an LH surrogate. So how would HCG go and bind on these things? Okay, guys, remember the follicles, no, they are going to have estrogen dependent development of LH receptors once they reach a particular size. This is simple physiology. I can explain this in the 2-cell to gonadotropin theory. Okay, these patients will have estrogen driven LH receptors as well as FSH receptors which are induced once they reach a particular size. Okay, and this LH receptors will go and bind beautifully to this HCG, will have a fantastic trigger, and you will be able to retrieve wonderful metaphase 2 oocytes in these particular type of cycles. Okay, what is important for people to understand in such type of situations? I would just erase some parts here to make some space. Okay, so what is important for people to understand is that whenever you are doing an agonist cycle, please remember this corpus luteum which gets formed, okay, is a slightly defective corpus luteum. So once you form your HCG trigger, and once you go ahead with the egg pickup, from the next day, it is better, should you be planning for a fresh cycle, to give these patients luteal phase support. Okay, and this luteal phase support to the patients in these particular type of cycles, so I'll just write it down as LPS, should be, especially when you are giving a fresh transfer, your protocol should include a combination of estradiol hemihydrate or valerate along with progesterone, starting approximately the next day of the oocyte pickup. Okay, on the next day of OPU. Okay, because that much amount of luteal phase support will be required due to the defect in the corpus luteum. The defect in the corpus luteum is obviously because of LH, absence of LH. So we all know this if we go through our previous sessions. Okay, now with this much understanding of this entire way in which entire way in which an agonist is to be stimulated or an agonist is to be done, there are some more practical things which I just thought I'll mention. Okay, see, this protocol otherwise is very, very standard. All right, sometimes people will complain that I have a small residual cyst on the second or the third day after giving this an agonist. Okay, so what to do in that situation? See, if you have the facility, always look at serum estradiol levels. If the levels of serum estradiol is less than 40-50, okay, aspirate that cyst, okay, and start your stimulation. Very important. At levels of estradiol which are so low, this particular cyst has been formed out of that small bolus of FSH which would have occurred on the first shot, okay, of giving your agonist. So you can manage it in this manner. Common question, no, but I have a cyst where estradiol level is 320. Okay, what do I do in that situation? Remember, in that situation, your cycle will have to be cancelled because this high value of estrogen at that point in time will cause a lot of asynchrony between the receptors, and this asynchrony of the receptors will not give you a very good outcome as far as agonist cycles are concerned. Okay. Second important question which people will ask is that instead of giving this daily agonist, can't I just give a GnRH agonist depot? commonly available Leupride depot is there, 3.75. Can't I just give that? And can I not just do the whole stimulation in the manner in which you explained? All right. So please remember, when you want to give GnRH agonist, all right, you got to wait for another 10 days. Though it will keep on secreting in bolus dosages, you must wait for 10 days prior to starting stimulation, because it takes that much amount of time to cause that profound suppression. Okay. The reason why GnRH agonist depot is not directly preferred is because that bolus dose can cause a slightly higher incidence of formation of that residual cyst and cycle cancellation, which is why people don't prefer that, which is why people prefer to use the 0.1 decapeptyl low dose. Okay. Which is why it is preferred like this. In fact, this pulsatile secretion is the basis of doing something called as flare protocol. So I'm going to talk about flare protocol, which I use quite a lot in practice, and hopefully it will give a lot of information on that day. But please remember, this pulsatile secretion is something of agonist which you can use to your advantage when you use that microdose. Okay. That is just something which you have to keep in mind. All right. Often people would say, is there a high risk of OHSS when you are using a GnRH agonist protocol? Look, this high risk of OHSS does not occur in the criteria which we mentioned. Okay. When you are looking at normal responders, when you are looking at endometriosis, when you are looking at people who have failed antagonist cycles, in all these situations, you got to choose. In all these situations, your agonist doesn't really cause OHSS, believe me. Okay. If people are so worried about this thing causing OHSS, okay, people are so worried. Look, the day you are giving your trigger, there is going to be no agonist which is going to be going in. Correct? Let's say you've gave a agonist with an HMG on, let's say, Friday, and you've called the patient on Saturday and you've decided to give the trigger on Saturday. There is going to be no problem understanding you are not going to be giving agonist on that day morning. You are anyway not going to do that. And in the night, let's say if you are triggering that particular patient, what is going to happen is agonist in that microdose will get washed off within 24 to 48 hours. Okay. After that, if you are worried about OHSS, the best thing you can do is give 2.5 mg letrozole daily to this patient once your egg pickup is done, provided you are doing freeze-all. That cannot be done when you are doing fresh cycles. I'm talking of freeze-all cycles. Just give letrozole. Letrozole will cause atrophy of that corpus luteum which has formed. Okay. And this letrozole which you add on, should you be freezing all the oocytes, it is something very, very good for the patient. No OHSS any which ways. Okay. Or it reduces the OHSS drastically. Correct. So just keep that in mind, because this is a common question which people want to ask as far as agonist cycles are concerned. Then people will often say that it is not very cost effective because you require a higher dose of HMG stimulation or RFSH plus Luveris or whatever you are using when you are using the agonist protocol. Yes, you are right. Sometimes the dosage is slightly higher. There is no doubt that dosage is higher because of the profound suppression which has occurred. But remember one thing, in the bargain of that higher dose, if you get 2 extra metaphase 2 oocytes, okay, and if you form 1 extra top quality embryo out of that, which we call as a TQE, it is definitely worth that 20,000 rupees extra. Okay. The cost to patient may be whatever, but the cost to you is not so much. Okay. An additional HMG, one extra unit of HMG, even if you have the worst deal in the country, okay, is not going to cost you more than 7 rupees. Okay. The best person is going to be able to procure it at 3.5 rupees. Correct. So 7 extra rupees per international unit, and let's say you are giving 100 international units extra, it is just 750 rupees. Okay. So it is not so much of a cost as well. Okay. So just keep that in mind as far as the agonist is concerned. I think apart from this, when we are talking of luteal phase stimulation in an agonist cycle for fresh transfer, I already mentioned my luteal phase support is estradiol hemihydrate, 2 milligram, 1 in the morning, 1 in the evening. And I give progesterone gel, 1 in the morning, 1 in the evening. Okay. I don't really give dufaston in fresh cycles as luteal phase support. It is not actually required for fresh cycles with luteal phase support. Progesterone gel plus estrogen is more than enough as long as you've used a agonist protocol. Okay. So with this, I conclude the basic information and the details of agonist protocol. Obviously, we will be able to take 3 to 4 questions like how we always do. And once we do these questions, the rest of the questions will be on WhatsApp.
Okay, I mean, that was very good and very clear. So as you said, the benefit of long protocol is the flexibility. I mean, you can start the stimulation either on day 3, or if you want to postpone it by 1 day.
Day 4, yeah, day 5, whatever.
So, is that one thing that, like, in batch IVFs, is this going to be an advantageous?
Yes, I mean, see, what is going to happen in the future in India is most of the country is going to get converted to batch IVF. Okay, because the way in which we have mushrooming of IVF centers, what will happen is it's going to be very difficult for an IVF center to sustain a particular number, even if they are the best. So they will want to divide their cases into batches where productivity is higher on those days. Definitely, when that happens, agonist cycles will come back into picture, because you can modulate for up to 5 days like that. You can prolong it by up to 5 days, which allows you a beautiful window, okay, to match all your patients and do an oocyte collection on the same day for everybody.
Yeah, and many of them will ask, like, what should be the interval duration between the last dose of agonist to the HCG trigger? Is it 12 hours, 24 hours? I mean, see, usually we give it doesn't matter, isn't it? Because the downregulation would have happened anyways. So what are the criteria that you take on day 2 or day 3 that it is completely downregulated? Like, what do you check? Do you check E2? Do you check?
I honestly just look at E2. Okay. So again, what has happened is that with agonist, we have standardized everything. When it is an agonist protocol, we do not use Lupride. Okay. I know people will tell 4 ml, 4 mg, such a cost-effective thing, use it. Very good. But if by mistake your nurse gives 1.5 on one day, 0.5 or the other day, the patient doesn't take it correctly. Who is going to be responsible for all these things, right? So this 0.1 PFS is one thing which we have standardized. Estrogen is second thing which we have standardized, that there is no change. Estrogen is mandatory to be given. Okay, I mean, estrogen is mandatory to be done at the time of starting the stimulation. And if the estrogen value is less than 40, as I said, if there is a residual cyst, we aspirate and we go ahead. But the residual cyst is going to be like 2 in 100, not more than that.
Yeah. So in cases of low ovarian reserve, where the cohort is not really uniform, and do you think, like, for low ovarian reserve also, the long protocol should be the first choice, or what has been your experience in this?
See, it really depends, right? What is your low? How low is your low? Okay, there are going to be patients with low AMH where you are going to say, I can see a cohort of 6 follicles. Okay, and I want to ensure that all 6 are stimulated simultaneously. That is a different perspective. Or you can have a low AMH where your antral follicle count is 3. Okay, so what I normally say is that when I am stimulating patients with low AMH, I don't really like to go ahead with agonist stimulation, because I want to ensure that I am doing a double stimulation if it is required. And if I want to do a double stimulation, it is going to be an antagonist protocol only. It is not going to be an agonist protocol, so I don't use it. But yes, there is enough and more literature available which says that you can use an agonist protocol and it will be very good, even if you have patients with poor responders and low AMH, and it works for people who do a single stimulation.
Okay, and you use HMG routinely for all your stimulations that we know.
Yeah.
But in case if people are using recombinant FSH, so when would they add the LH? What is the cutoff level of LH that you take that it needs to be added in agonist protocol?
See, in agonist, your LH is going to be very, very low.
Yeah.
Your FSH, native FSH and native LH is going to be very low. In fact, to be honest with you, this was one of the reasons why people did not want to, or people have started saying that for cycle regulation prior to IVF, don't give OCPs. The reason why they don't want you to give OCPs is that estradiol valerate, ethinyl estradiol along with any progesterone combination causes severe suppression of LH and FSH both. Okay, and it takes some time for them to come back. As a result of which, sort of that has gone out. So the same theory applies here. See, normally your LH suppression will be so profound, okay, that if you have a habit of measuring on day 2, day 3, your LH will be less than 1, honestly. Okay, try measuring it. And if the LH is less than 1, that means some basal LH is going to be required. That is how natural cycle is. Natural cycle has a basal LH of around 5, 6, whatever. Okay, that much you are going to require for adequate early meiotic changes and development of the oocyte If you don't give it that, and if you purely give recombinant FSH, you may have some, issues as far as the embryo quality is concerned. So if you want to do RFSH, Rec FSH plus Rec LH, please do it from the first day itself rather than waiting for the 5th day. That's not needed.
Okay. And what if there is a pregnancy in down regulation phase? Because do you check for the corpus luteum and then start the down regulation, or do you just give them because you have a lot of patients who come from outstation? So I don't think they would.
I just give them. I never look at corpus luteum, but it's a good practice to look at it. But I don't look into it.
Okay. And what if there is a pregnancy? Has there been any evidence which says that it ends up in a miscarriage?
So what typically happens is this particular thing is going to cause luteolysis. That is for sure. All right. This luteolysis would occur on the 3rd dose of your GnRH agonist. By that time, there will be some luteolysis in that corpus luteum. All right. So definitely the chances for this thing is going to be higher. I mean, there is no doubt in that fact. There is very little which you can do to rescue it as well. Okay. And nothing much can be done. But fortunately, so far, okay, I have not seen something like this in my practice where somebody has been given GnRH agonist, has become pregnant and has had a miscarriage. So that is not something which I have seen, and I don't want to comment on it because that is not something which I routinely do, because these are guys with severe endometriosis predominantly, which I am treating on GnRH agonist protocols, and it works very nicely in them.
So I've had 2 patients who conceived while they were on down regulation, but nothing happened, no miscarriage or nothing happened. So as you said, I think agonist protocol is one of the most standardized protocol, which I think is a go-to protocol when you said all those factors that you mentioned. So anything else you would add as an advantage to antagonist protocol that this agonist protocol has? Or
so I mentioned that in the starting itself. If you are looking out for that extra oocyte and for that extra metaphase 2 oocyte with an extra top quality embryo, preferably, see, it's different, right? When I'm looking at patients, predominantly the type of patients which we get have failed at least 1 IVF cycle outside. Let's say out of 100 new cases which we'll do in a month, we'll have 75 who have failed at least 1 IVF cycle outside. Correct? So then we will want to sit down and evaluate, was the previous protocol agonist, was the previous protocol antagonist, what was used, how many, what was the antral follicle count, if it has been documented. These days people are very secretive about documentation, so it becomes very tough to analyze what was the number of follicles which they saw and the number of oocytes which you get. Even that is very secretive, so it is pretty difficult honestly to identify in something like this. So again, we have one mental criteria for that. If people come to us who are normal responders, okay, normal responders on our ultrasound, and they come and tell us that, look, we did a previous IVF cycle, but we formed just 2 embryos, day 3 embryos. Then these are the patients in whom we would like to switch to agonist the first.
Yeah. So I think that's about it. I think we are good to go. Yeah. So we'll ask, what is TQE? You said TQE.
Top quality embryo.
Okay.
It is not my word. It is from that fertility sterility.
Okay. Yeah. Thank you so much. Thanks.
Okay.